Jalane Theis is a nurse practitioner in hematology and oncology with Texas Children's Hospital. Texas Children's is affiliated with the Baylor College of Medicine and is the largest children's hospital in the United States. I know Jalane because she, along with Dr. Monica Gramachis, have been the primary caregivers for our son, Brian, who is currently undergoing treatment for leukemia. He was diagnosed just over 2 years ago. I asked Jalane to conduct this interview as part of a fundraising effort with the Leukemia and Lymphoma Society, but there are other more broader objectives for this as well. I hope to generate awareness, greater awareness of childhood leukemia and other blood cancers by putting a human face on the issue. I also want to document an important part of our family's life. For myself, I'm already forgetting what it was like almost 2 years ago when he was diagnosed, but also for the kids, so that years from now they can go back and see what this was like for them and have a chance to look back at one of the most important people in our lives. The other thing, and also important in this, is that I would like to honor and also get to know better Jalane. She is somebody, along with Dr. Gramachis, who's really been saving our son's life for the past 2 years and continues to do so. So I can't thank you enough for that.
No, it's my pleasure.
And I can't thank you enough for doing this interview. Shall we?
Yes, go.
Let's roll. All right. And I have a lot of questions here. We probably won't get to all of them, but that's all right.
We can do all of them.
Okay.
But you do have several pages.
I have 5 pages.
Wow. Okay.
I've been thinking about this
Obviously.
for a long time. Let's start with this. The world of pediatric oncology is unfamiliar to most people. When somebody who doesn't know about this world asks you what you do, how do you explain it to them?
Oh, that's difficult. So sometimes I just say I get to go and play with kids all day. I think the word cancer scares a lot of people, or then they also think that we turn into saints all of a sudden. And we definitely know I'm not a saint.
Oh, we'll get to that. All right.
Oh, yes. Really, I talk about how much you all bless my life, how lucky I am that I can come along the side of you on an incredibly difficult journey, on a journey that just whaps you on the side of the head and you don't have any time to prepare for it. And I get to come alongside and help kind of put the pieces back together and encourage you guys. And then I get to watch these kids grow. I love it. I have been doing this so long now. I have kids who are married and having kids of their own, and to be able to see that and I'm just so proud of the kids I work with. They're amazing. They're resilient. They're beautiful. They come in here and fill this place with laughter. A lot of times you almost forget that they're fighting for their lives, just because they almost forget about it too, just because they're surrounded by so much love and they're like, yeah, this is what we're going to do today. Okay, let's go.
Yeah.
They have a very different philosophy on life than adults do. And I think it makes me not stress out about the small things as much, because we're fighting for lives every day. So it's just a different philosophy on life that I have.
Yeah, it's interesting. I would say I've probably learned more about courage and resilience from, my 6-year-old than anybody else.
Yeah, exactly.
Yeah, that's amazing. Okay, I'm going to ask you what the initials after your name mean. When I get an email from you, it says MSN, RN, CPNP. What do those initials mean, and in what order did you earn those initials? What's the significance? Tell me about that.
Okay, so the initials are Masters of Science in Nursing, Registered Nurse, Certified Pediatric Nurse Practitioner.
Okay.
So I went and got a 4-year bachelor's degree, a Bachelor's of Science in Nursing, so that's my RN.
And where did you do that?
Grand Canyon University. It's a small, it was small back in the day, Christian university in Arizona that had one of the top nursing programs.
Oh, okay.
And so I graduated from there. and then moved to Texas and moved to Austin and went to UT Austin for my master's degree, so my master's of science in nursing. And you get that alongside with your nurse practitioner degree.
Got it.
So my registered nurse, we learn everything from adults to children to infants. And then for my master's degree, I focused strictly on just pediatrics because I knew that that's what I wanted to do. And then I also knew I wanted to do oncology, and I already had been doing it. And so I traveled from Austin down to Texas Children's and would do extra clinicals down here, which is kind of what opened the door for me to get this job.
How did you know, so how did it happen, and how did you know that you wanted to be a nurse? How did you know that you wanted to work in pediatric oncology? What was sort of the trigger or sets of triggers for those decisions?
I always knew I wanted medicine, and I really went kind of back and forth between med school, and I don't really know why I chose to be a nurse over going to med school. But I do remember graduating from nursing school and going to my mom going, I'm just letting you know I'm not doing this for very long. I don't overly care for it.
Really?
Yes. Wasn't the biggest fan. Wow. But right about then, there was a lot of nurse practitioner programs that were coming, and nurse practitioners were getting a lot more of a name from themselves. And I liked that I could use my nursing degree, because I do like that part where we're all about teaching. We're about the family as a whole. And so the core of what nursing is, I do love. And then I was able to go get my master's degree as a nurse practitioner, and then I was able to develop more autonomy, get even more into the medicine side of it, almost like the medical school aspect of it, and build upon it. So then I can kind of do both passions, the teaching, the going alongside and encouraging, but with a lot more medical knowledge that my nurse practitioner degree allowed me to get.
Yeah, okay, excellent.
Oh, but why oncology?
Yes.
I've always wanted to do oncology. I had a friend who was diagnosed with cancer in high school, and he unfortunately passed away. And I think he probably had more of an influence on this than I realized. And then when it just came to doing clinicals and the different rotations, I always gravitated to oncology. I think it's the complexity of it, the relationship with the families, that we know each other for a long period of time, and that portion of it also appealed to me.
Very good. What is your work schedule? Do you work, is it Monday through Friday? And is it all here at the clinic, or there's a teaching component that you do as well?
So, yeah, for the most part, yes, I'm Monday through Friday, but we do, so new hires, so I'm also the assistant director of the nurse practitioners for the cancer center. So part of that entails any new hires, I'm working on their orientation, setting up for them to kind of rotate to see everything that incorporates what the hematology oncology centers are, but then we do a fellowship program for new nurse practitioners. It's a 3 to 4 month fellowship, and I run that program. And then I also started a support group for adolescents. And so there are weekend things for that. I'm doing camp several times a year and outings with them away from here. So.
And are these, so the teaching and the support group, are those things that you sort of volunteered to do, or
started them. Mm-hmm.
They were your initiatives?
They were my initiatives.
Oh, I see.
Yes.
And why did you do that? I mean, so nobody said, hey, we ought to do this. You just said, I think
we
it's
need
time
to do this.
Yeah.
Yes. I love adolescents. I love teenagers. Glutton for punishment, maybe, but yeah. I love them.
Okay. We'll have one for you in about 3 years.
I know. They sometimes are a lost entity up here. We are very kid-focused, and with teenagers, it's the time of life where they're developing their identity. They don't want to be different from their peers, and we take all of that away from them. You know, they're all of a sudden more dependent on their parents than what they want to be. They're no longer able to go to school. They're very different than their peers. And then they're also getting their chemo with a bunch of, 2 to 7-year-olds running around. And they're just like, okay, where do I fit in? And they're also really sick the majority of the time. And they don't get to meet each other as frequently.
I see.
As our littler ones seem to tolerate our meds better. And so it was just a need. a need for them to know you're not different. There are other people going through this, and your cancer doesn't define who you are.
And so what does that involve then? I mean, so you have you do some camps for them, or you do some other activities. What's the program structure around that?
So we have monthly on our inpatient unit. Our inpatient kids, our outpatient kids, whoever, our teenagers, 13 and up, can go and we do dinner and they just get to hang out together.
Oh, okay.
And it's normally facilitated, that one, by one of our psychologists. And questions will kind of get brought up that they can discuss. Normally I found with teenagers, they don't need a lot of prompting. They'll start having the discussions that they need to have, and we're just kind of there to help answer questions if they come up, redirect if we need to. But they know what they need, and they start the conversations with each other, and we just allow them to be able to do that.
Okay.
In June, we're going to go to iFly. So sometimes it's going...
What is that? Is that the indoor skydiving?
Oh, yes. So some things, if I want to go and try it, I just bring a bunch of teenagers along with me and use them as my excuse. But no, we've done no limits rock wall climbing. So we've gone in and done rock wall climbing. And that one was really neat because there were some who needed hip replacements or this and weren't as able to be as active as they wanted to be. But we could climb next to them and they could still reach the top of the wall. And it just gave them a sense of accomplishment and independence. We do camps. So yeah, there's 2 camps. YOLO, which is through the Periwinkle Foundation.
Yep.
We have one that's for younger kids, 7 to 15, and then we do 2 weekend ones for teenagers, 13 to 18. Weekend just to go and have fun. And then 3 years ago, I started one for our teenagers called Linking Lives. And it's a weekend where we go and do some team building activities, but also as a group, really talk about what it means to have cancer. How is it for hair loss? What were your fears when you went back to school? You lose friends up here. Not everyone makes it, unfortunately. How are you handling that your friend next to you is no longer here, but you still have to fight? And how does that affect you? And the guilt that they have for their parents. I don't think parents realize how much they try to protect their parents, how guilty they feel because of finances and the strain it puts on the family.
Right.
And it's an outlet for them to be able to talk about all of that in a safe environment with us who can give answers back and just kind of help them through all of that.
Yeah, well, that's awesome. I mean, I had no idea about that part of what you did.
Yeah, my philosophy is it's great if we heal your body, but if you don't walk out of my doors healed mind, body, and soul, I didn't do my job.
Yeah. Okay, and then on the teaching side of things, is that a requirement of the job, or this is just something you...
Well, I mean, I think I've been here for 11 years. Sounds really funny. I'm one of the oldest people that have been here the longest. So I think just, you get asked questions, and I do a lot of procedures, and I do procedures in our clinic. I go downstairs to our PACU, where our kids are fully sedated with our anesthesiologist. I do a lot of procedures down there. So I think just the amount of procedures I do lends itself to, I get asked questions, I go down and teach a lot, I go down and help if there's a difficult case.
Okay.
So some of it I think is just come with time, and I have the knowledge. And
okay, no, very good. What do you think, what makes a great nurse?
Okay, wait. Like a great nurse, like back here in the infusion room, or like a nurse practitioner like I am? Which one?
Okay, I'm going to say a nurse practitioner like you are. You can answer both, either, or, and.
Okay, great nurse practitioner. I think passion, empathy, knowing sometimes that you just need to be quiet, listening, knowledge, because you're entrusting your child with me. I need to know what I'm doing. Being willing to ask questions, because we don't always have the answer. Nobody does. It's medicine. It changes every day. And so being able and comfortable asking questions to those that do have the answer, or being willing to go and find the answer and doing the research for it.
Do you think you naturally, maybe naturally isn't the right word, but do you think you had those qualities or characteristics
I think
before
I think anybody that does pediatric oncology, that we're just hardwired this way.
Yeah.
I mean, what our personalities are.
And so then you stack the knowledge on top of that.
Yeah. We're all a little OCD type A.
Okay. I know why.
So, you're like, never say that part of you. Never. But yeah, I mean, I think who we are innately as people enables us to do this job.
Yeah.
And you have to have a passion for what we do, because there are hard days. And if you don't love this, if this is not where your heart is, it is going to destroy you.
Sure. Yeah.
For lack of, I mean, that sounds a little harsh.
No,
but.
I imagine that must be the case. And if we don't get to I have some questions around that. And if we don't get to them, remind me, because I want to ask about how you deal with what I imagine must be an incredibly intense day multiplied across 11 years and counting. So we'll get there.
We can get there.
And for you, so that's what makes a good nurse practitioner. For you in particular, because I think, one, Texas Children's is certainly one of the top programs nationwide, I'm going to say worldwide, in pediatric oncology. And they call you for some of the hardest procedures. So it's clear that you're one of the best at what you do. And then, we see it in our family. Even my mother, when I told her I was going to do this interview, she said, "Oh, Jalane is awesome." I mean, everybody knows that you're sort of in the elite at what it is you do. And I wonder, aside from what you mentioned, is there anything that you do that you think sets you apart from other people?
Oh, wow. Ooh, I'm sure that there is, but I just work with such an amazing group of people that we just all complement each other so much. I mean, I guess with me, my kids have no doubt that I love them and that I'm proud of them. And I try to tell them that almost every time I see them, so that I think and I'm sure other families feel the same way, but I don't go in on those office visits with all of my colleagues. But I think my families know for sure that I am there for them and adore their children.
Yeah, well, we had, I think that's a valid answer. I think from the other side, I would say that we had two instances where we could have made a switch. One was pretty early on in the process. I think it was after his day 28 exam, and he came back as high risk, and we were looking at, well, do we stay with Texas Children's? Do we go to MD Anderson? And we found out that they had two different protocols. You guys have two different protocols for how you would treat somebody in his position. And so we looked at, what, to the best of our ability, what's the difference in the two protocols? But a lot of it came down to how comfortable do you feel with the people that you go to see in the clinic. And so both of those factors weighed in, and now we have our family's moving to Fort Worth, so 4.5 hours away. And so now it's sort of a pure decision about, well, do you just sort of, the treatment protocol is the same, but it's a pure decision about, do you go and try to find another set of caregivers up there, or do you stick with the ones here? And it's no question, we'll fly or drive or do whatever we have to do. So if you move, you let us know, because we're going to have to change our plan.
I'll try to move up to Fort Worth if I do.
All right, good. Good deal. I guess, so you knew that you were going to be in nursing pretty early on. If it didn't, but there was a point at which you said, well, I don't know if I'm going to do this for too much longer. I'm curious, what was plan B? What else would you?
Oh, I think I knew I wanted to be a nurse practitioner right away. I knew I didn't want to be a nurse for an extended period of time, but I definitely knew I wanted to be a nurse practitioner.
Okay, all right.
And then honestly, if I didn't do this, I'd want to work for SportsCenter. ESPN.
But doing what?
Oh, interviewing the players, going to the games. I love sports. There's a part that you don't know about me. that I would want to work for ESPN.
Okay, tell me more. Why is that, or what sports?
Well, all
Just
of them.
all of them.
Because if you work for ESPN, I get to go to
You've
all
got
of
to
them.
know. Wow.
So that would just be fun. Totally random.
Okay.
But I'm not going to switch jobs. This is really what I love to do. But it really throws people when I say that.
Okay, I think we're going to start getting into some of the questions around the people, and you said before that if there's a way that if you're not sort of built for this job, basically it can destroy you. Mm-hmm. So anyway, we're going to start getting into some of those topics. And the question I wanted to ask you is, you have a very intimate window into people's lives. You see them, I think, in states of sadness and despair, and then you also see them in states of happiness and joy. You see the whole range, and you see it at a very sort of like personal and, I don't know, kind of gritty level. You know, like no matter who people are on the outside, like you probably don't know what I do. It doesn't, right? You just see people who come in and their kids are sick, and you see them in these wide range of emotions. Mm-hmm. How do you think about that? I mean, what does that mean to you? How do you deal with it?
I don't know.
Is it just part of the job, or?
Yeah, I mean, yes. I mean, part of it's part of the job. Part of it is we have to find a balance. You know, I mean, there are times where we have to sit down and cry with you all. There are times that we have to go and hold it completely together, giving bad news, or, saying that the cancer's back or whatever it may be, and then maybe going behind a closed door and taking a couple of moments. Because I think sometimes the hard thing for us is, even though we've come a long way and the survival rate is really high for our kids, it's still not 100%, even though that's what our goal is. And so it's giving everything to that family that's losing the child, but then also knowing that I need to be ready for the next one that comes into the door that's going to be needing me.
How many patients do you see a day?
I see about 10 a day, but that's like 10 on my schedule. Then there's like you all who potentially may just be coming in for a count check, and if there's a problem or a question or a change in the meds, we're dealing with that. Kids who are just coming in for blood or platelets, kids who are just coming in for chemo that don't need an office visit. So there's a set ones on our schedule, but then you're still kind of helping everybody else that's in clinic.
What's that? Yeah, I was just trying to get a sense of how quickly you have to move from one conversation to the next.
Well, it's pretty quick.
It's quick.
People don't like following me because I am almost 6 feet tall and I walk really fast around here. And you will see people who are shadowing me like running behind me trying to keep up. And I'm just like, just meet me. This is where I'm going. Just meet me when you get there.
And so what is that process of making the transition from one patient to the next look like for you? Let's say you've had it's probably different depending on the conversation, but let's say you have had a really difficult discussion with a patient or their family. How do you personally make that transition to the next thing?
So normally we have our own charting area where all the providers sit together. So I mean, in between patients, I'm walking into there, picking up the new chart, doing whatever I need to do, and then going into the next one. So it almost enables you to have a little bit of a reprieve where you can take a deep breath, you can talk to a colleague real quick, it just gives you a moment to collect yourself before you're picking up the next one and going in. And so it's just allowing yourself to take that breath and compartmentalize in some ways, shift it around in your brain where I need to go back to that later, but for right now I'm going to set it aside and be able to walk into the next room.
Is everybody that you work with equally good at that, or is there a range? I mean, do you see that some people kind of carry the previous conversations with them at all?
I think you have to be good at it. We're seeing too many patients and we're going too many directions that you have to be able to, like, everyone has their own little spot in your brain, so you just kind of keep going. Honestly, we just do it. I don't even really think about it that much, to be honest with you. It's just what we do. for what I do.
But I would guess that over 11 years that ability has evolved over time.
Definitely.
Is that fair?
Yes, no, definitely.
So do you see it, I mean, is that part of the teaching that you do for other nurse practitioners at all? Is sort of coaching them through that process?
And I probably need to do better at that, because normally what I'm teaching is a lot more like boundaries.
What does that mean?
So I think as a new provider, you can get so enmeshed in the oncology world that you forget that there's a world outside of here, that it's that work-life balance that, I mean, my pager may go off at night, I may be answering questions on the weekend, but it's also making sure that as a new provider, you need to be taking time for yourself. You need to, when you walk out of here, if you can, you need to go do something for you. You need to put oncology away. And that's hard to do because emergencies happen, things happen, and our families need us. And so it's just finding that balance, because there's so many programs, there's so many amazing things that are going on here that you want to be a part of all of it. And then you kind of realize at the end of the day, like, oh, I don't do anything but medicine, and that may not be the healthiest thing.
Yeah, I mean, there's always more to do, right?
There's always more
you could
always
do. Yeah,
always.
Yeah,
and I think you have to learn to be okay that some things are going to get left undone, and that you can pick it up the next day.
I guess this is a related question. How much of what happens here do you take home with you?
That is an art over time, I think. I think over the years I've gotten a lot better with leaving work at work and being able to kind of switch a gear and go home. You know, and a lot of people that are my friends work in medicine. So, I mean, it is nice that if you have a hard day, you can just say, I've had a hard day, and they understand what that means.
Right.
And it's, you know, going and having dinner with friends and doing other things where you're laughing and can take a moment from it. But that is something that has, for me, I can't speak for other people, but for me, that has just taken some time to really be able to develop.
You think you've got it mastered now?
Oh, I mean, there's always room for improvement.
Okay. I would like to know what advice you would give to somebody whose child has just been diagnosed with cancer. I mean, it's been 2 years for us, and it was a blur. So what advice would you give? And maybe the way I should do this is if your best friend or sister, you have a sister.
I do have a sister.
Somebody you cared deeply about, but couldn't treat because they're in another state or something. If their child was diagnosed with cancer, what advice would you give them? What resources would you point them to? What questions would you advise them to ask their doctors or nurse practitioners?
Oh, that would be really difficult because I would be flying there. I would be like, I would be all on those doctors. Like, what exactly is going on? What are you seeing? It would probably be a little aggressive. I would probably be driving my sister crazy at the moment.
If you couldn't, if somehow you couldn't, I mean, if you were,
but
you
in
just
general,
couldn't get there.
A new family, it will get better. It's hard, and we don't give you time to process it. We walk in the door and say, your child has cancer, and we got to go. And I think that's really difficult. I couldn't imagine somebody saying that, and you don't have time to deal with it emotionally, mentally. You're just like, in some ways you have to trust very quickly in these people that are walking into your room. And I think I personally would struggle with that a little bit. And so I think it would be, take a moment if you need the moment. Know that it's going to get better. The beginning is the hardest, and that is where the normal comes in. That this unfortunately does become your new normal. What your old normal was doesn't exist anymore.
History,
And it's a lot to mourn. It's the mourning of what your goals and dreams for your family were. And it's not that those are gone, it's just very different. And some of them do have to get put on the back burner because then the goal turns into focusing on the child. But I guess in that, I would probably say for parents, make sure you take time for the two of you, that the two of you don't get lost in this. Know that the two of you are going to cope differently. Doesn't mean one's right and one's wrong, but try to find a way to communicate with each other so it doesn't tear your family apart. And if you have another child, do something special for them so they don't get lost in the mix too. It's because it affects everybody, and it's hard for it not to. There's no way for it not to affect everybody, and it's, and so for some families, it's if there's a sibling, bring them up to clinic. Let them see what the sibling's going through. Let them be a part of it. Make sure that a grandparent can fly in if you have one and go do something special with that other one, but also do something special with the one that's going through the cancer. Yeah.
No, that's good. I mean, I certainly remember the day we received the diagnosis, and I mean, it's just like you say. The first question I asked was, well, do we have to do something? I always like to know, what are my options? Do I have to act or not?
Yes.
Do I have some time? Nope. We start right now. Okay. And I remember the doctor looked at me like I was even crazy for asking. And then I understood why. Okay, very good. Can you briefly, so little man has pre-B ALL, well, you know all that, high risk. Can you briefly outline for people who don't know what his treatment protocol looks like? And I ask that because even doctors, sometimes when we take him into the emergency room and we tell him he's being treated for leukemia, they'll say, oh, is he still receiving treatment or is he in remission? And you say, both. And they look confused.
Yes.
Sometimes people will say, oh, is he going to the clinic for his chemotherapy? Yeah, but he does chemotherapy every day. So can you just sort of describe for people who don't know what that program looks like for him?
Yes. Okay, so first off, just leukemia a little bit. So you have a stem cell that divides into a lymphoid or a myeloid cell. And within that, there are all types of leukemia, which gets really confusing for people because if you just say leukemia,
fair.
What does that mean exactly?
Yeah.
There's like quite a few different choices.
Right.
So you have your ALLs, that's part of your lymphoid line, and you have your AMLs, that's your myeloid line. And so your ALLs then further divide into either your pre-B ALLs or your T-cell ALL. And your T-cell ALLs are more very high risk, really intense chemotherapy. We worry about those kids. And then your pre-B ALL, that's what the majority of, that's the most common childhood cancer diagnosis is pre-B ALL. Most common age, about 4 to 5. But even within that, your pre-B ALLs, then we're looking at the DNA of the leukemia cell. And depending on what the DNA shows us can make you high risk, very high risk, your age, how will you respond within your first month. So there's a lot of other information that then kind of determines what any child's track is going to be. But for your high risk kids, like what Brian has, so the first month of chemo is crucial for us. It's how quickly is his cancer responding, and is he quote unquote in remission, where there's no detectable disease. We don't really use the word cure around here that much. I don't use it at all. I don't really like it. But remission is our goal for the first month of therapy. No detectable disease. And people are like, great, let's be done. I wish it was that simple. Because we still know that there are microscopic cells within the body that can regenerate themselves and take over again, that we just, with our technology, can't pick up yet. So then the next 6 to 8 months is very intense chemotherapy. More of it is either done in our clinic, it's done in the hospital, and we are using different types to attack the cells in different forms of their development. Some as they're already dying off, we're attacking. As they're becoming baby cells and growing, we're attacking. Mature cells, we're attacking them. So it's chemotherapy so the body doesn't, and the cancer cells don't become resistant to them. And it's intense. That's when they're feeling the worst. They're needing blood. They're needing platelets. But again, they're still in remission, and we're keeping them in remission. That's what our goal is. And then you go into maintenance therapy, which for girls is a year shorter than for boys, because boys, because of the testes, are a little bit higher risk. So you're looking at anywhere from like 2 to 3 years of maintenance therapy, where it is more at home, daily chemotherapy at home, where monthly therapy still given in clinic. And it's enough of chemotherapy where they're able to go back to school, they're not needing the transfusions, they're healthier, but yet it's enough chemotherapy that we're still attacking those cells and preventing them from taking back over is our goal. And then it's just, we look at how long are you in remission? A day, 2 days, 5 years, 10 years.
And then there's post-maintenance. So at the end of maintenance, he's done with the standard chemotherapy ends at that point, right?
Yes.
And then there's a period of checkups on his blood that will take place, and how long would that be?
Once you're ours, you're always ours. Once a month for the first year, every 2 months the second year, every 3 months the third year, every 6 months the fourth year, for about 3 times, and then once a year forever.
Okay. I know you've said that to me before, but now I have it on recording. So
you're always ours.
Okay. Well, that's good. That's good. Okay, you said something about the C word, the other C word, cure.
Oh, yeah.
Yes. I would like to know more about that. Cure is a word that I don't use either. The words that I see in the literature are event-free survival. So 5-year event-free survival.
Right.
So just talk a little bit about not using cure and what it is you do think is the appropriate way to look at sort of recovering from leukemia or cancer generally.
So I think, I think we sometimes all wish we could be God, but we're not. We don't know what's going to happen in the future. And so I think just using the word cure, there's some imaginable goal you're going towards, where really being in remission is a great thing. And every day that any child is in remission, the less likely it's going to come back. But have we had really rare cases where kids have relapsed 8, 12, 15 years post their original diagnosis? Yes. And it's unheard of. They should be quote unquote cured, you know what I mean? But we're looking a lot more at the event-free survival like you're talking about. The 3-year, the 5-year, and that's what our goals are setting. Our goals are how many kids at those time points are still in remission.
Right, so starting after maintenance, so at the end of maintenance,
really,
the clock starts, or is it before that when the clock starts? Even as soon as they're in remission, the clock starts. Oh, I see.
So
okay,
that's
so you
why
do
I'm
like
saying,
the day 28.
If you're in remission at day 29,
okay.
That is when our clock starts ticking. Because then if it does come back, if you're less than 18 months, then I can't find the word that I want. It's a late relapse or early relapse. And so if you're within 18 months from your first remission, that's an early relapse. Where if you're 36 months out from remission, your initial remission, day 29, hopefully, then that's a late relapse. And so our treatment is very different about what we would do to then go and attack the leukemia cells again.
Okay.
And then the event-free survival for us is also, we're waiting for that to get to 100%, where we're curing every child. And so it's a way for us to monitor how good are we doing in our job and what can we improve on for the kids.
We've got only a little bit of time left on that camera, I think. I guess you touched on this earlier. Well, you touched on it in your most recent answer, and then you touched on it earlier as well, that once you sort of induce a remission in somebody, it's not the end of the program. They've got maybe 3 years or more than 3 years still to go. And I guess I'm gonna, when I've done some reading on the history of cancer research, and my view of it is that there was a lot of trial and error and some success in the beginning with this. I mean, the side effects of all these drugs are intense, but the drugs are, of course, all designed to attack and kill the leukemia. And so the tension is always, well, how far do you push the kid? You've seen a remission, let's call it a day. and let's let them, return to school and stop feeling all the pain and the nausea and the baldness, versus, well, if we let up now, it may come back and it will be stronger and more drug resistant than ever. So with that wind up, where do you think we are in the state of, and maybe it depends on the type of leukemia, but where do you think that balance is right now? Do you think we've got it pretty well set, or where is that now? Is there a lot of work left to be done there? How do you view that?
So I think where childhood cancer is much different than adult cancer is, which I am thankful for every day, and I wish the adult world would get on board with this, is we have the Children's Oncology Group, which is a national organization that the majority of children's hospitals then join, so that from California all the way up to Maine, that every child in between is getting the exact same therapy. And so it's good because that they're getting good chemo, the latest and the greatest, but then you also have enough children that you're looking at which sounds bad, but we're also looking at the numbers. Are we really doing a good job? And we're looking constantly at what are the side effects. Are there too many side effects and we need to immediately close something and change what we're doing? And then there's a lot more international work that's going on than ever before, where we're constantly talking with what are the Germans, what are the Italians doing, what are they doing in Europe, which one is doing a little bit better. And actually our therapies are very similar to each other. We kind of take the best of all of us and combine it, and there may be a little bit of difference in, obviously there is in the different countries, but there's a lot of it that's very similar, which I think makes a big difference. And so I think on a whole, we're doing a good job. I mean, our survival rates in the last 50 years, if you got diagnosed as a child with leukemia, you were dying. In
months.
Very quickly. Where now, depending on what you have, really on a whole, it's probably an 85% cure, survival now, quote unquote cure if you want to use it. And that's great. And it doesn't mean that the other 15% are dying. It just means that their disease is coming back. And I think that's difficult for people need to realize that. We may say that there's an 85% survival, but that 15 doesn't mean that they're dying. It just means that they're coming back, and we have to reassess how we're treating them.
Right.
I think people also get the misconception that our kids are guinea pigs, that we're doing quote unquote research on them. And that's not the case. We're using things that we know work, that we are constantly looking at side effects. If we need to change it, we're changing it. There is a complete rationale of why we're doing things when we do them and what medicines we're using, that our children are not guinea pigs. And I think the word research just gives a bad connotation in people's minds, which I wish that they didn't have.
What would you call it? What word do you wish people would use? Or how would you like for people to describe it?
Oh, I don't know. I have never thought about it, because research is so much a part of what we do, because that's what pushes us and strives us to do better. I need the people to be doing the research. The research that Texas Children's does is just phenomenal. It's the CAR cells that even CHOP is doing, we're doing here, which is opening new doors for people. It's immunotherapy.
Is this where they use the HIV virus and sort of
so there's one of that. So there's a bunch of different ones, but there's immunotherapy. Really where things are going now is targeted therapy to the specific mutation, and it's specific to the patient and what they have. And granted, our meds are very targeted, but it's trying to become even more targeted. Like our Philadelphia positive kids, there are specific drugs that are going just for those Philadelphia positive kids that we wouldn't use for anybody else, because it wouldn't attack their type of cell. But how their leukemia works, we're using very specific drugs that are designed to target those areas. And so I think that's what a lot of the new wave, because we're really good at what we do, but we've at some point you kind of hit this plateau where you can't push much further because you're going to hurt them, and you can't push much further anyway because we're not going to get a better result. So then it's how creative can we get, and the creativity is what's really starting to happen now. Even vaccines
to sort of break through. Yeah,
and maybe even a vaccine one day for cancer is what they're working on. So people who don't like vaccines, you need to start liking them because they may save your life one day. They already do if you would use them.
That's right. Yeah.
Side note.
We'll get that in there. Do you? Well, I guess the other thing, in my own readings of leukemia and the potential causes of childhood leukemia, so ALL, for example, is that a lot of it is just unknown. I mean, there's like radiation.
Yeah.
But
you maybe were randomly exposed to something.
yeah,
but
a lot of it just seems random.
no, you just had bad luck.
Bad luck. That's right. But there's also this. But I'm going to say that maybe the science isn't there yet. I mean, it could be just bad luck, or it could be that there is a cause and we just haven't found it. That's right. That's possible.
Definitely. I think that is the hardest thing with leukemia, is people are like, how did my child do this? I mean, I have one kid who refused to go to a certain McDonald's and play on their playground because he was certain that that's how he got his cancer. I'm like, baby, that's not how you got your cancer. But we as humans are striving for why. Why did my child have this?
Yeah.
And we do not have that for leukemia.
Yeah.
It's, the adult world, you have a lot of gene mutations or this or that, and you see some of that in childhood cancers, but there's a lot of unknown.
Okay, this section I called random questions.
Oh, great.
Because I had some themes to some of the others. So I'm just going to hit a few of these, and then if you get tired, just tell me. What do you think is the most misunderstood aspect of your work?
Again, this is more my pet peeve, is I do not think, and which is why I'm glad you're doing this, that cancer doesn't affect the people in Houston. Like, the majority of Houstonians have no clue that they have the largest cancer center in the nation in their backyard. No clue. Or that we diagnose about 600 kids just with leukemia a year. We have a large population of kids that have cancer right here in Houston, and really all over the United States, that I wish that people knew that there are families that are struggling, that they most likely have kids in their neighborhoods who are going through some sort of cancer treatment. And that, and maybe, yes, it is uncommon, but for me it's very common, and so maybe that's why I'm a little bit more passionate about it, but St. Jude's is not the only place kids get treated.
Yeah. Well, I mean, this whole world was totally invisible to me.
Yeah.
Until my son was diagnosed. And I feel terrible about it in a way because, I've known people like friends of friends or family members of friends who, so-and-so has cancer and they're having trouble walking today. And you say, well, man, that's bad. But it never really hit me. And even when the little man was diagnosed, I knew it was bad. But one of my first thoughts was, why does everybody say this is bad? Like, what is it about leukemia that's scary? What is it about cancer that's scary? And it's only in going through the, it's just a day-to-day grind for a prolonged period of time. That even for the kids and for the kids who make it through, it just tears their world apart. And so that was something that I didn't understand. But yeah, that's a big part of what I think, we're trying to do with this whole program. The fundraising and the video and the blogging and all of that is to try to, for people who otherwise wouldn't be exposed to it or have a reason to be exposed to it, is just sort of show what it's like. Because as you say, these kids there are quite a few of them out there. And they don't make a lot of noise. They don't, they just want to be normal. Like you were saying about the teenagers, the kids just want to be normal. And they don't want to, he doesn't want to show people his port or his port scar. It's just a natural thing, I guess.
And I guess the other thing would be, is I think when they hear kids with cancer, that's just so sad. It's heartbreaking. There's a lot of laughter that goes unto, and I wish that people would know that. Yeah, there's struggles, but man, there's a lot of laughter in the process.
Yeah, excellent. Good point. Yeah, we've had a few good laughs, I can tell you that. Can you describe the relationship, sort of like the emotional connection that you have with patients? And in particular, what I'm interested in is, like, would you say that you have an equal amount of compatibility with your patients and their families? Or do you have, say, for whatever reason, you have a stronger bond with one and a stronger bond with the other? And it's sort of the follow-up is, how do you manage that? To what degree is it important? That sort of thing.
Mm-hmm. I think it's really important not to have favorites. This isn't the environment for favorites. It's not fair. This is not this. Don't. So I'm a big proponent and do not have favorites. Yes, I think I treat all of my children the same and all of my families the same, and they get the same type of care from me regardless. But then on the flip side, do you just bond with some families more than other families? Of course. I mean, I think that's just kind of our genetic makeup and who we are, that maybe you're a little bit more bonded to them. But I think, like, on a whole, the care I give and how I treat them all, the respect, the love, that is the same, definitely across the board for me.
Okay. How would you advise somebody who thought that they had an interest in becoming a nurse practitioner today? So Jada, who's running around somewhere, she's thinking about it. I mean, she's only 10, but she's thinking about it.
I mean, wonderful.
What would you advise maybe somebody older than 10, but we can take a 10-year-old? I mean,
come shadow us. Find a nurse practitioner in your community. If your pediatrician's office has a nurse practitioner, go and shadow. I think shadowing is the best way, because unless to fully understand what the role is, you have to see it. And
how young can the shadows be? How little?
Well, normally they have to be high school or older.
Okay, all right. Okay.
And ironically, there's a lot of our kids who either become nurses, nurse practitioners, or physicians after being in this world.
They get something of a shadow experience. I mean, not the full thing.
Yes, they do.
They spend a lot of time here.
They become experts on quite a few things.
Okay, very good. That is really all I had, unless there's something. Is there a question I should have asked you that I didn't?
I think so.
That you wish I asked you?
Kind of covered everything.
Candace,
is there a question? Or Brian, do you have a question?
Little man, you had a question for Miss Jalane. You want to come and sit in the seat and ask her your question? Come on. You don't get these opportunities every day. Come on. Come on. Just come on over and sit with me.
Yeah, just come whisper it in my ear even. What did you want to know, love bug?
That is an excellent question. So, bad cells sometimes go and hide there. And so I'm looking at it to make sure that there's no bad cells. So that's why. And sometimes when they were,
so you know how this is them, okay? But sometimes when bad cells go there, one can start looking like really big, almost like you have like an orange there or a golf ball. That would not look normal, would it? No. And so you would be able to notice. And so if you ever saw something that looked like that, I would want you to tell mom or dad, but that's why I'm looking. It's a really good question. I know, because it can be kind of weird, huh? I agree. Do you have anything else? Okay.
JD, do you have a question for Ms. Jalane? Okay, hold on. Let me give you the microphone. May I? Do you mind if may I? Young lady now. I got to be careful what I do here. Okay. All right. Whoop. There we go.
Do you like being a nurse practitioner?
I do. I love it. I absolutely love my job. I would not want to do anything else but this. It's fun. I get to race down the hallway with you all. We get to have fun together. It's great. I get to meet people like you and like your brother and your family, and we get to know each other really well, and yeah, I like it. And I like medicine. I like trying to figure out the answers and seeing how it all works together and how we can make things better. That part's fun too. I'm a bit of a nerd.
That's good. So are you, huh?
Yeah.
That's a good thing. Anything else you wanted to ask? Anything you wanted to say to Mr. Lane?
I don't think so.
Okay.
Sounds
All
good,
right.
baby.
Well, good.